Yeah, so I think we're at the point now that the vast majority of the myeloma community embraces maintenance. So I would say, unless proven otherwise, people should get maintenance. And as I was mentioning, lenalidomide is the standard. For those patients that have high-risk features, of course, we add the proteasome inhibitor. There's several clinical trials that have done so with bortezomib, but we switch just for convenience to ixazomib. I think there's a couple of questions that are remaining. One is what other drugs, should we use? So, for instance, I think it's not hard to envision venetoclax being used for the 11-14 maintenance, and we want to understand how monoclonals may play a role there, either elotuzumab or daratumumab. Last but not least, very, very important, for how long to do maintenance? No one has the answer to that. I think most trials support that if you treat for longer, it's better, but of course that comes with a price, with toxicity and side effects. So to that effect, the one tool that might help with that is the measurement of MRD, which might help people go one way or another regarding discontinuation of therapy.